The goal is
Mhm.
not to get a test back that says like zero bacteria. The
Mhm.
goal is to ameliorate symptoms and prevent, complications from urinary tract infections.
Today we're talking with Dr. Kumar, who's based in New York and is a women's urology specialist. And she has a special interest in hormone treatment, recurrent UTI, and IC. So thank you so much for taking the time to speak with us today.
Thank you so much for having me. I appreciate it.
Maybe you can just tell us a little bit more about your background so people have some context for your work.
Sure. So I went to medical school at Tufts from 2002 to 2006, and that's where I became very interested in urology. I did my residency at NYU Langone Medical Center here in New York from 2006 to 2011. And when I came into practice, I was seeing about 75% female patients. And certainly recurrent urinary tract infections was a big part of my practice. And I always felt that what we were doing wasn't enough. And there were so many frustrated patients dealing with this issue. And so I really wanted to learn as much as I could and focus my practice as much as I could on helping women who suffer from recurrent infections, as well as other irritative lower urinary tract symptoms, which can arise from things like interstitial cystitis, or also what we call the genitourinary syndrome of menopause, which not only affects the vaginal tissue, but the bladder, urethra, and pelvic floor as well. And so, as I continued to focus my practice, I also decided to learn more about menopause and estrogen, and I became a certified menopause practitioner by the North American Menopause Society. And then at that point, I decided to focus my practice exclusively on treating women. And I decided to set the whole practice up as a practice that is by women and for women. And so that led me to open up my practice where I am now, which is called Women's Urology New York.
Yeah, I think there's definitely a need for that kind of practice. There are so many people that we hear from in that position. I want to start with something basic with the questions that we've received, which is just around testing. So maybe you can give us a bit of insight into the limitations of standard urine culture and why so many seem to come back negative, even though people still have symptoms.
Sure. So that's a great question. So standard urine culture is based on a technique where you take very small amounts of urine and you drop it on different plates that have certain nutrient media. So one could be like chocolate agar, one could be blood agar. And a couple things can happen. One is that you may not have enough quantity of urine to accurately reflect the bacterial population in the urine. Two is that you may not grow it for long enough. The bacteria may take a much longer time to grow than you're actually observing those plates. And three, the composition of nutrients on the plate just may not accurately reflect the composition in the bladder. And so the bacteria, while it's thriving in the bladder, may not grow on the plate. And even, studies that show a technique of expanded urine culture testing, where they actually use higher quantities of bacteria. They use higher quantities of urine volume on the plate. They use more types of nutrient media, and they use a longer time where they observe the growth, are shown to be more sensitive than the standard cultures, that are typically used by the labs that we send the urine to.
And do you access that kind of expanded culture through your practice, or do you use something else for testing?
So in our practice, what I actually like to do when I have patients where I really strongly suspect that they do have a urinary tract infection and their standard culture is coming back negative, then I do find there's utility in using the urine PCR testing or the urine DNA testing. shockingly, in New York, the labs which offer that testing are not approved. I actually just had this conversation with someone from Pathogenic last week. They don't have something called New York State approval. And so we are like the only state in the country where it's difficult to order the tests. Some of my colleagues have actually set up urine PCR labs in their office. And so now I have colleagues who I can refer to get it done in New York. And then other than that, I have to rely on, using a urologist who's in New Jersey or Connecticut,
Right.
In order to order something like the MicroGenDX.
I see. We do hear from a lot of patients in New York that they're having difficulty accessing anything but a standard culture. Do you think in the near future that might change, or is this likely to be a long-term issue?
I do think it will change. I think that, given the demand for the testing, more offices will be able to set it up. I know that Dr. Cavalier, who's one of my colleagues, she has set up a urine PCR lab in her office. It's taken her over a year. You have to get CLIA certified. You have to have a lab director. So there's a lot that goes into it. I think other practices will follow. And I also think that, those companies are actively pursuing New York State regulatory approval. So I think they'll be available here. And hopefully that happens sooner rather than later.
Yeah, that would be great. So for people that have had like negative standard urine culture and do have pelvic pain of some kind, do you think they can benefit from these other kinds of tests?
Yes, I do. I think that certainly in the patient who shows on the urinalysis some white blood cells, leukoesterase, certainly the patient who is showing that there are signs of inflammation in the bladder, and the culture is coming back negative. In that patient, I'm very suspicious that they do have a urinary tract infection, and, they are falling into that 30% of patients who are getting a false negative standard culture. The other situation that I think it's very useful is that some of the tests are actually able to detect resistance genes. And I think if you have a patient who, has a positive urinalysis, has a positive culture, and they're not responding to the antibiotic you have them on, then it's helpful, because your standard culture, the way the resistance is determined is also, a fairly crude technique, and you may be getting a more accurate characterization of the sensitivity and resistance profile with the PCR or DNA testing. So, so I think, there's various ways in which that testing is useful. But, I think that I would, as a first measure, still send a standard urinalysis and culture. And then if I find it's necessary beyond that, then I would use the DNA testing, because there's a large percentage of women who come in with UTI symptoms. We do the standard test, it comes back positive, we treat them, and they feel better.
Right.
So I think that, it's useful in the population of patients where their symptoms are persistent, and we think that the standard test just isn't correlating with what we're seeing clinically. Given what we are starting to understand about the urinary microbiome, our goal with treatment is not to sterilize the urine. And I think that was one of the questions, is whether, what is our endpoint with this? Our goal is to ameliorate symptoms, and our goal is to prevent complications from urinary tract infections. And so complications can include things like, pyelonephritis, where the infection ascends up to the kidney, although very few people actually get pyelonephritis from urinary tract infections, or urosepsis, which, is when the bacteria actually enter the bloodstream. So, that's our goal. Our goal is not to sterilize the urine. And I think, from what I've seen, multiple patients who've been on so many different rounds of antibiotics, both orally and intravesically, and they're still having symptoms.
Yeah.
Those are the patients who you really need to consider, that this 20,000, colony count, or this presence of, a little bit of E. coli or enterococcus, or, a variety of different organisms in the bladder, or I shouldn't even say in the bladder, because we don't know if it's coming from the bladder. It might just be permeatal. It may not be the cause of their symptoms. And I think, because infection is so common in the female bladder, we always, I like to actually do a very thorough job in ruling that out. So I don't think there's anything wrong with making an attempt to treat it. But if your patient is not getting better, then you need to, rethink whether this is actually infection, or you're just detecting some bacteria from around the urethral opening or the vagina that's not really causing the problem.
The ability of these other kinds of tests to pick up more organisms means that patients also often get a long list of things, and their doctor might tell them that certain organisms, they're just normal, they're meant to be there, and therefore they won't treat them. Do you think there are times when organisms like ureaplasma or lactobacillus could be pathogenic and then therefore should be treated?
Ureaplasma, yes. This was actually part of Dr. Ackerman's talk, where they actually found that treating ureaplasma in patients in the absence of pyuria did not make a difference in symptoms. Ureaplasma is a very interesting organism, because that is a test that you can order in the office, and that is like a DNA based test. And so, I have had patients certainly where treating it has improved their symptoms, and when they've seen other doctors, they keep getting a standard urinalysis and culture, and they're not testing for mycoplasma, ureaplasma. I've seen where, I've treated with the one dose of azithromycin, and the symptoms didn't clear, but when I treated with a longer course of azithromycin, that, like, the patient totally felt better afterwards. I think if I see ureaplasma in a patient who has irritative bladder and urethral symptoms, I am going to treat it. It is a commensal organism. I've seen women who've had urinary tract infection with E. coli, and then we've also detected ureaplasma, and their symptoms have cleared just with the treatment of the E. coli. So I think, again, you really have to take into consideration the information that you have, and then you have to use clinical judgment in order to determine what you're going to treat, because you do want to minimize antibiotic exposure to the extent you can. And as we discussed, the goal is not to sterilize the urine. The goal is not to get a test back that says like 0 bacteria. The goal is to ameliorate symptoms and prevent, complications from urinary tract infections.
That is kind of a difficulty with the switch from the standard culture to these other kinds of tests, because patients and clinicians, I think, are expecting it to be positive or negative. But the tests that are actually looking more at the urinary microbiome, surely we're not trying to eradicate everything now that we know that there are things that should be there.
Right.
So how do you kind of draw the line when you're doing treatment like that and decide which one should stay? Is it all just about how the patient feels?
I think there are certain like known uropathogens. And so, if we're seeing that there's a predominance of those, and the patient's having symptoms, let's say there are 2 bacteria like, E. coli and Pseudomonas. And, in that situation, I think, apt to treat both, especially if, let's say, the patient has done a standard culture before, and we've been treating the E. coli that grew on that, and they're not responding to it. So I would go based on what we know to be, the organisms we know to cause urinary tract infections. And I think that, if the patient has been on antibiotics and they're not getting better, and like it's something that these bacteria should be sensitive to, I think then, and especially if they're doing a voided specimen, then we have to say, look, these bacteria, they live around the meatal opening. They live in the perineal skin. These are commensal bacteria, and we shouldn't be treating it. So the other thing is, I think if I'm doing that test, I really favor doing a catheterized specimen, because I think if we're doing voided specimens for that type of testing, then it's very similar to doing a vaginal swab.
But a question I have is, if they are using a catheter sample, what if the infection is in the urethra? Do they not just miss the problem then?
No. So you still can get bacteria if it's in the urethra. You still can detect it in the catheterized sample. And in fact, catheterized samples don't do as good a job as we think in avoiding vaginal contamination. I see that all the time in my office, where I check a catheterized specimen in a woman, and it is, she's totally asymptomatic. And, I might be checking it just to see how well she empties her bladder. It might, for other complaints than UTI complaints. And, I see it all the time where we detect like 50,000 E. coli, 20,000 Enterococcus, strep viridans. So catheterized specimens can often give you bacteria that are perimeatal and from the urethra. The only way of checking a true bladder specimen is by doing like a suprapubic aspirate, which would be, invasive in most people. So we don't routinely do that. But so I do think that, trying to limit the amount of contamination by doing a catheterized specimen is, if you're going to do something like a MicroGenDX test, I think is wise.
Okay.
And I don't know that you necessarily miss urethral bacteria. The one thing that you can miss is, I think there's a population of women who end up with an infection in the Skene's glands, which are the glands which sort of sit on the outside of the urethra and are homologous to the male prostate. And that's a situation where you have a patient who's complaining mostly of dysuria, and they've maybe had a UTI previously, but the urine is culturing negative now. And sometimes you can detect some tenderness on exam at the sort of mid to distal urethra where those glands are. We typically think of the Skene's glands when they form a cystic structure or when they may erupt into the urethra and form a urethral diverticulum. But I think that there's probably a population of women who have infection or inflammation in those glands, similar to how men develop prostatitis. And you kind of have this chronic smoldering infection, and it would be very difficult because the bacteria is being sequestered in the gland. So it would be very difficult then to culture that.
Yeah, there's a lot of discussion amongst patient groups actually that urethral syndrome could be Skene's glands being infected, because the symptoms just seem to be around that area. How do you detect whether it is a Skene's gland problem, and then how do you treat that?
So it's really hard because, again, you can't rely on your urine result if you believe that the bacteria is being sequestered in the gland. So that is a situation where I will give the patient, in order to treat it in the same way that we treat male prostatitis, you need a longer course of an antibiotic which has good tissue penetration. So the antibiotic getting excreted into the urine is not enough. So you need something like a Cipro or a Bactrim or an amoxicillin where you're actually getting into the tissue and you're achieving that tissue concentration for a long enough period of time. So I will usually prescribe like a 4-week course, and then I tell the patient, you need to let me know, by 7 days or so, if this is helping you, because if you're feeling no relief in your symptoms, then I want you to stop it, because then I don't believe that, this is a Skene's gland infection. If you are feeling significant relief with the antibiotics, then I think it, makes sense to continue.
Is surgery ever an option for that kind of issue?
So if the gland forms a cyst, sometimes the gland will actually fill with like pus. And if you can palpate, a cyst under the urethra, or you can even image and see it on MRI, then yes, you can surgically remove it. But unless it's enlarged, it would be very difficult to actually, localize and dissect out the gland.
Okay.
And so I think surgery is an option if it presents itself as like a cystic structure, or, in the case that it erupts into the urethra, it's a urethral diverticulum. And most women, want surgery for that because they're experiencing dribbling or, chronic infection. And so that usually will become symptomatic. If it just forms a cyst and it's not actually communicating with the urethra, sometimes women will feel that as like a suburethral mass, or they'll notice their urinary stream is diverted. Sometimes they don't feel it at all, and we just detect it on exam. And so if it's enlarged, you can excise it. But if it's not, then you don't have anything to find and dissect out and remove.
Right. And when you say urinary stream is diverted, does that mean it is actually passing through a different piece of anatomy?
No, it just means that if there's a structure that's sort of pressing on the urethra, you may notice that when you urinate, your stream is getting diverted. You may say, my stream always aims to the left. And then when we examine you, we find a Skene's gland cyst, on the right side. Sometimes they can get quite big, and so they cause a little bit of compression of the urethral opening.
Yeah, that makes sense.
And I think that even in the absence of infection, sometimes those glands can be irritated hormonally. And, those glands are actually testosterone sensitive. And so one thing we sometimes see, especially in women who are on the birth control pill for a long period of time, those glands are kind of irritated and inflamed, even in the absence of infection. And using a little bit of like a compounded cream that has both estrogen and testosterone can actually help to soothe the irritation in the glands and provide symptomatic relief.
That's interesting too. I wonder how many clinicians approach it that way, because I think a lot of clinicians don't consider the Skene's glands in the first place.
It's a very overlooked.
Yeah.
It's an extremely overlooked structure, certainly.